Welcome to Study Session 6, Administration of an Enema. Introduction. An enema is a fluid injected into the lower bowel by way of the rectum. The most frequent use of enema is as a cleansing enema, which is given to relieve constipation or for bowel cleansing before a medical examination or procedure. In standard medicine, an enema may also be employed as a lower gastrointestinal series to check diarrhea, as a vehicle for administration of food, water or medicine, and as a stimulant to the general system. In this study session, you'll be learning about the purpose of enema administration, assessments of clients prior to enema administration, and finally the actions involved in enema administration. Learning outcomes. When you have studied this session, you should be able to 1. Identify the purpose of enema administration. 2. Carry out client assessments prior enema administration. 3. Identify the nursing actions involved in enema administration. Enema. An enema is a solution introduced or instillation into the rectum and large intestine in order to distend the intestine, thereby increasing peristalsis and the excretion of feces and flatulence. Enema is categorized into 4, namely, cleansing enema helps to remove feces, carminative enema helps to expel flatulence, retention enema introduces oil, medication or nutritive solution into the rectum and sigmoid colon. An oil retention enema acts to soften the feces and lubricate the rectum and anal canal, thus facilitating passage of feces. Medication-based enema is administered to treat local infection, that is antibiotic and anthelmintic enema, while nutritive enema administer fluid and nutrients to the rectum. Return flow enema helps to expel flatulence. Purpose of enema administration: to relieve constipation or fecal impaction, to expel flatulence, to prevent involuntary escape of fecal matter during surgical procedure and delivery, to promote visualization of intestinal tracts during radiographic or instrumental examination, to help establish regular bowel function during a bowel training program. Preoperative preparation for bowel surgeries. Types of enema solution: hypotonic, e.g. tap water; hypertonic, e.g. sodium phosphate solution; isotonic, e.g. normal saline; soap solution, e.g. soap salts; oil, e.g. olive oil and mineral. Assessment of clients before enema administration. 1. Assess status of client: last bowel movement, level of awareness, normal bowel patterns, hemorrhoids, mobility, external sphincter control, abdominal pain. Rationale: determines factors indicating need for enema and influencing the type of enema used. Particular care must be taken when inserting rectal tube to reduce irritation of hemorrhoidal tissues. Use generous amount of lubricating gel to reduce friction when passing rectal tube. 2. Determine client's level of understanding of purpose of enema. Rationale: allows nurse to plan for appropriate teaching measure. 3. Check client's case notes to clarify the rationale for the enema. Rationale: determines purpose of enema administration, preparation for special procedure, or relief of constipation. 4. Reviews physician's order for enema. Rationale: order by physician is usually required for hospitalized clients, used to determine how many enemas clients will require, type of enema to be given, that is oil retention, carminative, medicated. Possible nursing diagnosis. 1. Constipation. 2. Pain. Related factors are individualized on a client's condition or needs. Equipment: disposable gloves, Macintosh and towel, toilet paper, bath towel, bedpan or commode, clean gloves, water-soluble lubricant if tubing not lubricated, wash basin, wash clothes, towel and soap. Enema can or bag for administration, large volume enema. Other requirements are jug containing water or solution when enema can is to be used, enema can or bag, tubing and clamp, appropriate size rectal tube, correct volume of warm solution, or prepackaged enema for administration, large volume enema, prepackaged container of enema solution with lubricated tip. Implementation. Prior to the procedure, explain process and anticipated response. For example, some abdominal cramping to clients and encourage clients' participation and questions. Lessens anxiety and promotes clients' participation. Assemble equipment. Rationale. Optimizes use of time, conserves clients' and nurses' energy. 3. Provides privacy by using the screen or close the room curtains and door. Reduces embarrassment for clients. Wash hands and apply gloves. Reduces transmission of microorganisms. Raise bed to appropriate working height for nurse. Raise side rail on opposite side. Promotes good body mechanics and client safety. 3. Assist client into left side lying position with right knee flexed. Children may also be placed in dorsal recumbent position. If client is suspected of having poor sphincter control, position the client on the bedpan in comfortable dorsal recumbent position. Clients with poor sphincter control cannot retain all of enema solution. Rationale allows enema solution to flow downward by gravity along the natural curve of sigmoid colon and rectum, thus improving. 4. Place Macintosh under hips and buttocks. Prevent soiling of linen. 5. Cover client with bath towel, exposing only rectal area, clearly visualizing anus. Provides warmth, reduces exposure of body parts, allows clients to feel more relaxed and comfortable. 6. Place bedpan or commode in easily accessible position. If clients will be expelling contents in toilet, ensure that the toilet is free. If clients will be getting up to bathroom to expel enema, place client slippers and bathrobe in easily accessible position. Used in case client is unable to retain enema solution. 7. Administering enema using prepackaged container of enema. Remove plastic cap from rectal tip. Tip is already lubricated, but more jelly can be applied as needed. Gently separate buttocks and locate rectum. Instruct clients to relax by breathing out slowly through mouth. Rationale. Breathing out promotes relaxation of external rectal sphincter. Insert tip of bottle gently into rectum. Gentle insertion prevents trauma to rectal mucosa. Squeeze bottle until all of solution has entered rectum and colon. Most bottles contain approximately 250 ml of solution. Hypertonic solutions require only small volumes to stimulate defecation. Instruct clients to retain solution until the urge to defecate occurs, usually 2 to 5 minutes. Administer enema using enema bag. Add warm solution to enema bag can. Warm tap water as it flows from faucet. Place saline container in basin of hot water before adding saline to enema bag. Check temperature of solution with bath thermometer or by pouring small amount of solution over the wrist. Hot water can burn intestinal mucosa. Cold water can cause abdominal cramping and is difficult to retain. Inserting a rectal tube in enema administration using enema bag. Raise enema container, release clamp and allow solution to flow long enough to fill tubing. Removes air from tubing. Reclamp tubing. Rationale. Prevents further loss of solution. Lubricate 6 to 8 cm of tip of rectal tube with lubricating jelly allows smooth insertion of rectal tube without the risk of irritation or trauma to mucosa, gently separates buttocks and locates anus, instructs clients to relax by breathing out slowly through mouth. Breathing out promotes relaxation of external anal sphincter. Insert tip of rectal tube slowly by pointing tip in direction of client's umbilicus. Length of insertion varies. Hold tubing in rectum constantly until the end of fluid installation. Bowel contraction can cause expulsion of rectal tube. Open regulating clamp and allow solution to enter slowly with container at client's hip level. Rapid installation can stimulate evacuation of rectal tube. Raise height of enema container slowly to appropriate level above anus. 30 to 45 cm for high enema, which cleans as much of the colon as possible. 30 cm for low enema, which cleans the rectum and sigmoid colon only. 7.5 cm for infant. Allows for continuous slow installation of solution. Raising container too high causes rapid installation and possible painful distension of colon. High pressure can cause rupture of bowel in infants. Note: installation time depends on the volume of solution to be administered and client's ability to withstand given infusion rate. Lower container or clamp tubing if client complains of cramping or if fluid escapes around rectal tube. Temporary cessation of installation decreases the possibility of intestinal spasm and premature ejection of the solution. Clamp tubing after all solution is instilled prevents entrance of air into rectum. Place layers of toilet tissue around tube at anus and gently withdraw rectal tube. Provides for client's comfort and cleanliness. 10. Explain to clients that feeling of distension is normal. Ask clients to retain solution as long as possible while lying quietly in bed. For infant or young child, gently hold buttocks together for few minutes. Solution distends bowel. Length of retention varies with type of enema and client's ability to contract rectal sphincter. Longer retention promotes more effective stimulation of peristaltis and defecation. Discard enema container and tubing in proper receptacle or rinse out thoroughly with warm soap and water if container is to be reused. Reduces transmission and growth of microorganisms. Assist clients to bathroom or help to position clients on bedpan or commode. Normal squatting position promotes defecation. Observe character of physics and solution. Causes clients against flushing toilet before inspection. Note: when enemas are ordered until clear, it is essential to observe content of solution passed. The enema return is considered clear when no solid fissile material exists, but the solution may be colored. Normal squatting position promotes defecation. Assist clients as needed to wash inner area with warm soap and water. If perineal care is to be administered, use gloves. Fissile content can irritate skin. Hygiene promotes client comfort. Remove and discard gloves and wash hands. Reduces transmission of microorganisms. Evaluation. 1. Inspect color, consistency, amount of stool and fluid passed. Determines if stool is evacuated or fluid is retained. Note: abdominalities such as presence of blood or mucus. Assess condition of abdomen. Determines if distension is relieved. Unexpected outcomes that may occur include abdomen is rigid and distended. Rationale: results from perforation of bowel. Enemas should never be given when appendicitis or bowel obstruction is suspended. Abdominal cramping occurs. Results from excessive volume or incorrect temperature of instilled solution. Recording and reporting. Record pertinent information. Type and volume of enema given. Characteristics of result. Rationale: communicate pertinent information to all members of healthcare team. Improves documentation of treatment results. 2. Report failure of clients to defecate to physician. Rationale: may indicate need for further therapies. Follow-up activities. Stop enema if severe cramping, bleeding, or sudden abdominal pain occurs. Physician should be notified of any adverse effect. For an effective understanding of enema administration, the following points must be borne in mind. Proper positioning of client in seams position is very important in the instillation and retention of enema solution. In cases of severe cramping, bleeding or sudden abdominal pain during enema administration, the procedure should be stopped and reported to the physician. Tap water is a hypotonic solution, can be retained within interstitial space because it exerts lower osmotic pressure than the interstitial space, which can lead to circulatory overload. Therefore, precaution must be taken and should not be repeated after the initial administration. Summary of Study Session 6. How to assess a client's prior enema administration. The purpose of enema administration. The nursing actions or rationales involved in enema administration. End of Study Session 6. Thanks for listening.